Lovely, thank you. So good evening, everyone. For those who don't know me, I am a community specialist paramedic with North West Ambulance Service. I've been part of the end of life care group based within NWAS for the last kind of 2 years or so, maybe a year and a half. So really our role, if those that don't know the CSP post in NWAS, it's mainly geared towards delivering safer care closer to home is the buzz statement that we all kind of live our roles by. We get involved in various kind of interests linked to the role, and mine really being end of life care. For those that watched the recent webinars with CPDme, there was Carol, one of my colleagues on in Cheshire. She did a frailty webinar, so definitely worth checking that out if you haven't already. End of life care, the aims of my presentation really. I want to discuss what we've been doing in NWAS and the priorities for what we've kind of established, the background of how we've got there, the knowledge, hopefully just to give you almost like I wouldn't say a simple guide, but it's one that works for me, and I'm quite well. I wouldn't say I'm simple, but I do like things being easy to read, easy to interpret. So hopefully that's the thing we can achieve. And the documentation and terminology as well, and specifics to make things legally binding and non-legally binding. So moving on, end of life care and why we're really interested in it, why I'm interested in it. We all know, and for those that are familiar with the 5-year forward view, the aging population that we all live as part of as well, and we're all contributing to that as well, really. I find that as ambulance staff, we are called to a lot of end-of-life care incidents. We are involved in these incidents, whether we want to be or not. We seem to come across these quite complex patients in the community, and they do present quite unique challenges and very, very difficult decisions on some occasions. I know myself, I've been involved in some, so I know that others will have been as well. A context for NWAS as well, really. We need an update to our guidance. We need an update to the toolkits that we use. So that's part of what the steering group's looking at locally for us. 𝐥𝐤𝐤 as well, the last update in 2016. There is things that do really need to be added into there that I'll cover later in the webinar. The other thing that I found recently, this was undertaken by the End of Life Care Steering Group again as part of the NWAS Medical Directorate. We looked at an internal staff survey, and of 121 staff, I mean, the main trend was that, very similar to the poll, that we found more people weren't confident as opposed to those that were confident. And again, we just wanted to make sure, really, as a trust, that we were doing patients justice, and we were providing like high quality care in these situations, really. So I guess the aim of end of life care is to provide sensitive, quality care for everyone kind of in the dying process, regardless of their kind of part of the journey where they're up to, really. So with the end of life care group, I'll explain a little bit, because this was initially what we identified as part of the 5-year plan. The 6 key kind of areas. Older adults with frailty being one, which Carol sits on that group. End of life care that I sit on. There's maternity that a few of our clinicians sit on as well. We've got quite a good coverage, really. Mental health and dementia was combined just due to the overlapping kind of complexities there. And sepsis, that all NWAS clinicians will know it inside and out from the pathways that we've got. But we hoped really that the group would provide a decrease in the number of individuals who are admitted to hospital, especially those that had a wish that they wanted to die at home and they wanted to have their treatment at home. We also really wanted to reduce the number of individuals that are transferred between facilities, because as we know from transferring these people, it's not a comfortable journey. We again don't have the greatest roads in the Northwest, so it's not the best way to transport someone around if we're doing it a lot. Education is a big part of this group as well, and that comes through everybody's role, regardless of whether they're a clinician, like EMT, nurse, paramedic, various levels of clinician, or our kind of non-clinical staff, really, our non-registered clinicians and our ambulance kind of care assistants as well. So anyone from patient transport, call, what will we call them, dispatchers now, EMDs as well, anyone that has a part in a patient's journey. The aim was to combine a few kind of sources of information. So we were looking at the gold standards framework, preferred priorities for care, and I'll go into that a little bit more shortly, Northwest anticipated clinical management guidance, as well as an education package for our staff. So I think that's the key thing really, like knowledge is power. So far, and the successes that we've had, Matt Dunn, who's my line manager, he's the end-of-life care lead for NWAS as our consultant paramedic for Lancashire. So he's a very busy person. End-of-life care is something that's quite close to his heart as well. He does put a lot of time into it. We've got everyone as part of the group, really. Every service line is represented, kind of reporting into Matt Dunn for this end-of-life care strategy group. So literally 111, there's PTS. I'll probably miss a service out, and I do apologise if so. There's PES, that's Paramedic Emergency Services, that are represented as well. There's people from finance that are involved. You know, there's someone from every area of the service that at some point will be involved in the group. There's project management team as well that are currently working on something with the group, which, you know, is really key to how we develop the future. That kind of initiative that the project management team are working on is something in partnership with Macmillan, and Southwest Ambulance Service have kind of developed a really good blueprint for end-of-life care. They initially, it was more geared towards cancer care and palliative care diagnoses, with the kind of the broader aim of developing that care to a really good standard, which would kind of influence the whole end-of-life care kind of umbrella, really. We did also take part as part of trust. So we were Northwest Ambulance Service NHS Trust, one of many trusts across the Northwest. So we were involved in some what we call anticipatory planning guidance, which I'll just get rid of that notification. The anticipated planning guidance work group. So this was kind of about building guidance in an easy to interpret place, and I'll show you that's available soon as well. Let's buzz that off. In terms of other discussions with other trusts, we did have some with, I believe it was over in, there's Northeast that have been doing some work as well, but the main stuff was from SWAST, really. We've had a few conference calls with SWAST as well, have been really helpful. We've got lots of regional forums, national forums as well. We've also agreed an education package with Health Education England. We've got some e-learning that's coming online soon, thanks to 𝐤𝐤𝐤 and his hard work on that side. The CSPs, so the community specialist paramedics, do quite a lot of work regarding kind of advanced care planning, which I'll go into very shortly. So there's a lot happening, and there's a lot that we want to happen in future. But really what I want to kind of gain in this webinar is just to give you an insight of how I see kind of our place in end-of-life care. And by ours, I mean ambulance staff. So I like to define kind of planning status, as we say, as split up into kind of these four categories. And the one that I want to focus on first is this kind of personal area of care. So this is usually by the patient. This is someone that wants to write their kind of wishes down, and this is a means of kind of them getting that onto paper. So personal needs planning, it should be personal, it should be by the patient, really. It should kind of involve very like practical things, I guess. So looking at, we do look for deterioration with these plans, but this is mainly looking at the here and now. Looking for people that might need a walking frame or a personal alarm. It's things that we do without really realising as ambulance clinicians. Practical help, maybe from a paid carer or organisation. Access to day centres and lunch clubs. Sort of kind of social prescribing, which was a new term to me within the last kind of 2 years or so. So just looking at prescribing something non-medical for someone, that could be part of this plan. So it could be part of getting them out and about and enjoying the time of kind of their end-of-life care journey, because it doesn't mean that everyone is immediately dying, that they have a plan in place, really. in the notes, I put some links in there for people to look at afterwards as well, if you want to read a little bit further into it. I think I've put links on quite a few slides just to show where the information's come from and just to see if anyone wants to gain any further insight. There's a little bit more on there. Advanced care planning. So you might hear of advanced care plans. You might hear of advanced care planning. To me, it's the same thing. It's just about the content that goes into these plans. So it's a discussion between the patient and those who are caring for them. It should be a very inclusive discussion. It should be patient-centered. It should provide for that patient, and they should be the one that really dictates what goes on to their kind of advanced care plans. But yeah, the process in itself, we just want to see wishes, really. We want to know what that person wants. But I really do want to kind of clear up some things that were quite difficult for me to understand initially, especially with the legalities of things. So how I organise it in my mind, this is probably the best way that I can put it onto paper. You've got advanced care planning in the middle as kind of the umbrella, and then I've split it in half. So you've got your non-legally binding kind of parts of advanced care planning at the front, so at the top, and at the bottom you've got the legally binding elements of that. And I'm going to cover each of these individually just to go over kind of what it means and what we would see and what it might look like on scene as well if we're seeing these patients. I would really recommend, and I'm going to kind of plug this further into the slideshow, I'd recommend getting onto an advanced care planning session, because it's really good to be able to ask a few questions. It's usually palliative care services that deliver them, and they're more than happy to discuss things, and they'll clear everything up right there. And then that's how I've learned this knowledge, really. So an advanced statement, in terms of things, it can be as basic or as kind of complex as the person wants, but this is non-legally binding, remember. So this is literally, it's a document that says what their wishes are. It's reasonably informal. It's not something that we need to follow, but it's something that we should really follow if we've got an idea of what that person wants. You could fit things like the respect process and a DNA CPR into here, and I'll cover that separately. Yeah, really, the document can be modified. People can change their minds with this, and it can be cancelled and amended regarding kind of whatever new information becomes available. So an advanced statement, you see the document on the left, it might literally just be expressing what they want to happen to the dog, what they want to happen to the house, to the property, the financial things that we kind of take for granted, like what had happened to any outstanding finance. So we might find those wishes here, but we also might find these plans, and that's what's really important for us on scene, because it'll give us an idea of where that person is at, really, with their mindset, and we can make a much more kind of holistic decision once we've got that in our minds as well. Preferred priorities of care, so preferred place of care, things like that go into these booklets. You might see it in a booklet format as well. And again, it's just wishes of what that person would ideally want to happen. And I mean, these come into play when the person loses capacity. Again, it's not legally binding, but it's what that capacitous person would say to you, I guess, if they could speak, or they could relay that information in a way that keeps with the Mental Capacity Act. So, spokesperson. I won't discuss the man on the slides. I'm sure there's shared views of whether you'd want him to be a spokesperson or not. The spokesperson, again, it's a verbal method of an advanced statement. That's how I see it. It's non-legally binding, it's informal. This person is speaking on behalf of the patient, so it might be next of kin, and you might see on an advanced statement that they've nominated a spokesperson, so they've put someone in place to speak if they can't. Or again, this does go into a little bit more of a, if you want to look at the Mental Capacity Act side of things, and for those that are aware of an independent mental capacity advocate, I've put that kind of under the heading of spokesperson in the notes. But an IMCA, as we call them, as we term to them, they're only there to ensure that the Mental Capacity Act principles are followed. That's their role. They're not there to speak on behalf of the patient. They can be appointed to a patient if they've not got any family, if the family don't want to speak on the patient's behalf. and aren't able to make a decision for the patient, say they're not available, again, if they don't know the patient well enough, an 𝐬𝐚𝐽 would just clear up any controversy really, and they'd be able to just make sure that the Mental Capacity Act was followed by the clinicians. So moving into legally binding ones now in red kind of pen. I've had a couple of incidents where I've been presented with differing documentation. The one on the left is your lasting power of attorney financial affairs. They can't make a decision regarding healthcare for the person. They can tell you what to do with the house if that person wants to die and the finances, but we should really be focusing on the lasting power of attorney for health and care decisions. And this document on the right is from the Office of the Public Guardian. There's a couple of things that happen really when this is in place. The person that's kind of documented on it as being the deputy for the patient. If the patient loses capacity, the deputy is kind of giving guidance on what they can and cannot do. They can kind of provide a little bit of an insight into that person's wishes as well. But again, it's a legally binding insight this time. So they can tell you what that person would want. They can also make, again, decisions on kind of health records. They can provide consent for certain procedures. They can apply quite a high standard of care and can get professional advice from clinicians and make that decision as if it's that kind of person really. What they can't do is stop life-sustaining treatment. So if someone has this in place and they're telling you they've got lasting power of attorney, we've really got to be wise that, I mean, the legislation that underpins this says that they can't stop life-sustaining treatment. Really, we need other documentation in place for that. And it links quite nicely into another document that we'll look into, an advanced decision or advanced decision. Sometimes this is termed a living will. You see some of these sometimes, advanced decision to refuse treatment, purple paper, red paper, bordered document. It should be a headed document that's very, very, very specific. If you can think as kind of, what's the word, specific as you want to be and be as awkward as possible, that this is what this document should be. It should be literally, you should imagine it, there's someone stood there going, no, not that, yes, this, no, not that. And this document should really be quite wordy, I think is the best way to put it. Patients must be 18 years or older. And I mean, for a lot of these documents, I am speaking more towards adults. I'll go into the paediatric side briefly towards the end. It must be signed and dated by a witness. It must be also very specific to the treatment. And so, for example, I refuse cardiopulmonary resuscitation, inclusive of, and this is for our assumption of cardiopulmonary resuscitation and a definition of it. So that we're talking about ventilations and chest compressions. It must also include in that statement that that person understands that refusing that treatment could cause them serious harm or death. That needs to be written down ideally. And we're not going to kind of ignore it if it isn't written down. We just know that that document isn't one that's going to stand up as a legally binding document because the terminology on it is not correct. I've seen varying levels of ADRTs in practice. I've seen some where I've made a decision on them, and now knowing what I know from the training that I've done towards advanced care planning, I thought, oh, that is a little bit questionable. However, it just builds that decision for you. You know, it just gives you a little bit of knowledge about what that patient wants. So if this doesn't have kind of these legally binding points on it, and I've listed them in the show notes as well for people to go through at a later date if they wish to, then really we'd be treating it as an advanced statement because it's not a legally binding advanced decision to refuse treatment. So that's the difference between the two. Advanced statement, non-legally binding, presents someone's wishes. Advanced decision to refuse treatment, big red writing, specific, very, very holistic in terms of it needs to document and say that they know that they could die if they withdraw or refuse that treatment. These only come into power as well, as with every document, if the patient loses capacity to make that decision. So moving on to kind of planning status for clinicians. Predominantly this is done by the clinician. with the patient involved. So these are very clinical sounding plans, if that makes sense. So to differentiate two kind of categories, the personal categories at the top and the clinical ones, I just imagine the bottom one is predominantly the clinician writing it down. The top kind of ones, advanced care plan and personal needs, predominantly the patient should be writing their wishes down. Or if a clinician is writing it, they should be seeking as much from that person as possible. So moving into a clinical care plan, those within NWAS may have seen these plans. I'll be honest, I only maybe saw a handful of them before I took my role as a CSP. They do sometimes get hidden on scene, they get lost. They should be on yellow paper so that they're very visible. And patients that have them generally have long-term conditions. So this clinical care plan, and kind of using it as an example, it's a document, again, for the here and now, and it's telling you clinically what's normal for this person. And then on the reverse of these plans, it gives you a kind of a pathway for if they present with these known symptoms. And when we say known symptoms, things like COPD patients, so those respiratory patients that have long-term conditions, if they present with breathlessness and a reduction to their oxygen levels, we could probably document that quite nicely on here, knowing that their baseline could be 86% and they run at that no problem. Respiratory teams wouldn't worry about that. We might worry a little bit and go, actually, we're not happy to leave you at home with that level. And we'd start delivering kind of lower levels of oxygenation to that patient. Because I know I've done that before and I've not really had an idea if that level's normal for the person, because as we know, patients can be poor historians on occasion. The oxygen warning cards aren't used to the level that I'd really like to see them used in the community. I mean, patients put them in the wallets and purses, and I guess they forget they've got them, or they receive it and put it in a drawer, like I seem to do with a lot of cards. Like my club cards and everything. So I think that's where we'll find the oxygen warning cards. But moving past the clinical care plan, so just to reiterate, this is the here and now clinical kind of, this is what's normal for the patient. Moving into, I mean, and I really, really like the document that we've got that underpins the points on this slide. It is really, really useful. I spent a lot of time reading it. Anticipated clinical management plans, again, very similar to advanced care plans. But as I mentioned before, you need to differentiate these and clinicalize them. So this is very, very clinical in a way. The anticipated planning guidance talks about other documents though as well, which is nice. So they're written by clinicians, not patients, as mentioned. It doesn't mean that you shouldn't involve the patient. No, the patient should really be central to everything that we're doing. I think that's the main point with end-of-life care, really, that we involve the patient and the people around them as much as we can, and we listen to what they say. This document that I've just put up on the right-hand side, that was a final draft. It's now published with the North West Coast Senate. NWAS had good kind of input into that as well. I remember sitting on some conference calls and discussing this documentation. Really, I'd used the document on the right, and I've put some links in the show notes again. I'd used that document as like the kind of, well, I say the end-of-life care kind of guide in a way. It guides documentation especially. I got a lot of information out of this. But an anticipated clinical management plan, generally, and how I view these is it's anticipating that person is going to go downhill and is going to deteriorate in future. So an anticipated clinical management plan in the literal sense, we're talking about things that discuss just in case medications, discuss kind of further plans and treatment for certain presentations. So it's slightly different to the care plan that discusses the here and now. This is more discussing if this person was to present with something that isn't known to them but could present in future. So we're talking about respiratory kind of airway secretions, noisy breathing, the conditions that do scare families in these situations. They scare the patient, but generally with that kind of noisy, crackly breathing that we do hear, that some term it as a death rattle. Which I've never really used that terminology myself, but it's the best way to describe it in your mind, if that makes sense. Very, very kind of rattly chests that we listen to that you can usually hear from the end of the bed. But patients generally are quite relaxed with that. They just need some medication to remove the breathlessness. So things like morphine that can be given in these situations. I'm not advocating that kind of my NWAS colleagues go out there and start administering morphine for that kind of scenario, but it is definitely being discussed, possibly for future. So it's just about treating symptoms that could appear rather than symptoms that are known to appear. That's where we differentiate between the clinical care plan and the anticipatory clinical management plan, and that's the difference between the two. I do want to discuss RESPECT and unified DNA CPRs. Unified do not attempt cardiopulmonary resuscitation, just because it is quite, well, it's a controversial topic on Twitter. I have had a lot of tweets from various people on Twitter about this. These forms, they're really advanced statements. These aren't advanced decisions to refuse treatment, so they aren't legally binding. I think that's the real key take-home message, that these don't form a legal decision, that they're not there to say this definitely must happen because it's now legally bound. They're not legally binding. They are to be followed, you know, to the best of our knowledge. These are a representation of a futility if that patient was to be resuscitated. It's the expression of either that patient that they don't want to be resuscitated, or it's the expression of a clinician that knows that patient, that knows that they would not survive a resuscitation to the same level of kind of independence prior to the cardiac arrest. They can be cancelled and amended. This is the kind of the key thing, that it gets very, very complex if we start talking about cancellation and amendment of DNA CPRs. So all I would really say is share that decision. I'm going to talk a little bit more about shared decision making, but don't do it on your own. You know, you can always start basic life support until one of these documents is known about. The links that I've got in the show notes for this slide, the NWAS resuscitation policy that was kind of revisited and revamped by the medical directorate with some good input from research in the trust, from other sources outside the trust. It's a solid policy. It's one that I would save it on my phone to have it handy. I know that sounds quite quite geeky, but it reads well and it gives a lot of information. For those that aren't aware, there is now the kind of the adaptation of the diagnosis of death forms within the North West Ambulance Service. They now they contain a section about palliative or kind of longer term conditions that would not be expected to provide a recovery post arrest. So there's specific wording in this policy that is really, really useful to read. But as always, the DNAR and the RESPECT form, they should overlap with discussions with the family if they're written by a clinician. They shouldn't just be put in place willy-nilly. They need to be in place for the right reasons. And there is variation with RESPECT forms. There's certain areas that are kind of putting them into place, there's certain areas that aren't. It wasn't a mandatory thing to put RESPECT in place of new DNA CPRs, which is frustrating because it would be nice to have one document across the Northwest. But really, we should just be using these to get information from. So I hope that makes sense in people's minds, that they're non-legally binding. They're just there to represent either a person's decision or a clinician's decision that they don't want to be resuscitated. And if we have good knowledge that one is available, again, we can make a decision with that information until like further information becomes available. The one thing I just wanted to clarify before I move on, again, photocopies were a point of kind of contention in the past. They are acceptable photocopies of these documents. However, we don't want to encourage photocopying because it basically means that it's getting duplicated. So these records, there should only be one of them, and we should keep that with the patient or person. But I do understand that we sometimes are presented with a photocopy in the heat of the moment, and it's, well, that's not real. You know, it's not the proper copy. But we can follow the guidance on that. We should just really be wanting to keep that sole first copy, the original, with the patient. So I'm not going to cover this with a lot of detail because I know that we can all assess capacity. We do it to quite a high standard. I just wanted to put this in there to point people towards kind of things that would help them with capacity assessment. On the e-learning for healthcare modules, so if you type, in fact, I think it's in the show notes. Yes, it is. If you go on it's 𝐸-LFH, and it's NHS email login only. The tool on the right, the third one, furthest to the right, that's a downloadable PDF, and I've got that in my work phone for when I get any complex kind of cases, any complex decisions. It's a College of Paramedics accredited kind of tool, and again, it's just going to assist with decision making. That's all this documentation is there to do. It's not there to put clinicians under pressure and force them to make decisions that they shouldn't be making. It's there to give them information and to allow them, if possible, to escalate that decision or to share it with someone as well. Pediatrics, I'm not going to go into this too much because it's quite a rarity to see these incidents as a frontline crew. Crews that do go to these incidents, they're very, very memorable, they're very, very emotive. Children with life-limiting conditions, again, it's a very, very difficult presentation to deal with. But there's some good guidance out there to read around. Every document that you've seen so far, apart from the ADRT, the advanced decision, that could be in place for these patients. Legally, there's a lot of things in the press recently about parents having decisions for those under 18. It does usually sit with the parent to be discussed with the clinician, but when there's kind of disagreement between the two parties, that's when the courts need to be involved to add that kind of independent outlook onto the matters. My knowledge is quite limited on that side of things, but reading through these guidelines, there was a lot more information on there that I could kind of interpret and read into. I think there's a guide on here as well. It's a guide for end-of-life care in one of the links in the notes, and that is pediatric kind of focused, but that gives you a little bit of there's a little bit of a flow chart about having difficult conversations, and that is kind of duplicated to adults as well. It's quite useful. So I think one of the most important points I can really raise, it's just working with the people on scene, you know, including everyone in that team decision. Don't be afraid to escalate that decision. I mean, in NWAS, we're quite lucky that we do have 24-hour 7-day-a-week, 365 days per year. We have access to senior clinicians, whether that's a senior paramedic, whether that's an advanced paramedic, community specialist paramedic, consultant paramedic, all the way up to the medical directors as well. Decisions can be shared with every level of clinician if they need to be, just going through that chain of kind of seniority, really. And again, I guess the main thing with sharing these decisions with those senior clinicians, they more likely will have been involved in these situations in the past. That's not a kind of 100% they must have been involved in these situations, but they'll generally have taken an advice call similar to the situation that you find yourself in. I've discussed a lot of things over the phone with a lot of different clinicians, and I've got a lot of really good information from those discussions. So the most important thing I could really share is, and it's a difficult one to see where we fit into this, but I really do feel that we need to talk a little bit more about what we want in future, regardless of how old we are. It's seen as something that you should only do when you're getting older. But, I mean, I've got a mortgage and a house, and I know that many people have the same. People have pets, dogs, fish, cats, you know, various animals in their homes. If you want to write down what you want to happen to, you know, worst case scenario, if something was to happen to you to remove your capacity, having it written down and talking about it. I'm not going to preach too much about it because it's a very sensitive subject. It's very personal to people. Some will have their own reasons for talking about it. Some will have reasons not for talking about it. But again, there's more value in having it written down than not, in my mind. That's my opinion. Again, people may disagree, but I think having it on paper in good planning, it can be updated, it can be changed. So anyway, I won't preach too much about it because I know it's still very much a taboo subject, but hopefully that will change in the future. NWAS staff that are on the webinar, we've secured funding with Health Education England to deliver end-of-life care training for everyone in the service. So this isn't limited to just clinicians. Again, we've got everybody is part of this. So we've got Paramedics can be involved. They can apply for the full day training. We've got EMDs and dispatchers that can go for the morning sessions, just get a kind of an overview of what documentation and difficult conversations, communication skills. A lot of them possess, I say a lot of my colleagues possess very, very kind of developed communication skills, because that's their kind of key trait over the telephone. So again, learning how to adapt your current style is quite useful. Other resources that we can kind of look into as well. I mean, and for the last slide with the NWAS staff, there's a link in the show notes to book that training. Should have an email hopefully about it as well somewhere in your inbox. But further resources, there's various ones, and these are all in the notes again. Andy Knox in the top right, that video is really useful. He's really passionate, Andy. He gives a really good talk. Really good guy. He's a GP up in South Cumbria. Probably North Lancs, depending on which organisation you speak to. Podcasts are powerful as well. There's a lot out there that you can just stick it on in the background while you're driving. I've got a few that I listen to reasonably regularly that I've put in there. There's someone from Atul Gawande about his kind of experiences. They're down as what we call a REITH lecture, REITH lectures from the BBC in 2014. He was fantastic, to be honest. His books are very good as well. MDT podcast, there's bits in there about advanced care planning. The 𝐦𝐨𝐫𝐞 palliative medicine podcast is about research and kind of patient participation in end-of-life care treatments. And that is it really for me. I'm more than happy to attempt to answer some questions. Any that I can't answer, I'm more than happy to take them to the end-of-life care group. If anyone provides emails and things, or if I'm able to get some form of contact details for people, I'll try and get the answers out to them. But yeah, I'll do my best to answer them. So yes, thank you for listening.
So this question's from Oliver Kieran. It says, where a patient doesn't have an end-of-life care plan, should we be challenging GPs, etc., to organise them, or is it a document we can implement?
I think it's a difficult one to implement when we don't know the patient, especially speaking from an ambulance background. If we've just met that patient, it's very, very difficult to form a full kind of plan. But what it is possible to do while we're on scene is just to find out this information and to kind of organise it in our heads as an advanced care plan. So to ask questions about what that person wants. If we can speak directly to the person who's got capacity, fantastic. That's it. You wouldn't use any documentation with that. You'd speak to the patient. But again, that's not a common or a true representation of pre-hospital practice. So if the patient has lost capacity and we've got someone on scene that is kind of telling us what we think might be the patient's wishes, all we can do is work on what information we do have. So if we have information to suggest that that person wants to be treated at home, say we've got two people on scene, wife and husband, possibly both. Again, I'm going to make it very well, I guess a common presentation to what we come across. So two elderly people on scene. Again, we might term that they're frail, and we might start to think, actually, Bob really knows what Mary's wishes are. Oh, she doesn't want to go to hospital. She was in there for X amount of weeks. I'd rather she was treated here. I think if we explain everything that we were wanting to do to that person, we can almost use them as like an informal spokesperson. But again, if you're making decisions on information that isn't documented, your paperwork needs to be absolutely tip-top. And I'd always share that decision. The other part of the question about kind of challenging GPs on this, I think we should almost be challenging patients on this as well, because we can challenge GPs as much as we want, but a lot of the time the GPs, in my experience, do want this to be in place, but the patient doesn't consent and doesn't want it in place. So I think part of it's education from us with patients, and part of it is really letting the patient know what it's all about, because we've got a bit more kind of protected time with that patient than the GP might have. You know, we're with them sometimes upwards of 30 minutes to an hour and a half, you know, through the journey that we've got with them. So I hope that answers the question, but don't ever forget that you've got the opportunity to share any difficult decisions, regardless of which service you're working in. There's always someone to speak to about a decision. So just make sure you follow your local policies with that, really.
Excellent. Thank you, Kieran. I think that's answered the question. Well, our next question is from Albert Holden. Albert's asked, hi, Kieran. If a patient is unconscious, how do we know as an ambulance crew where the advanced statement is located and if the patient actually wrote it at all?
I think this is where technology plays a key part in future. As a trust, NWAS-wise, we do flag addresses through something called ERIS, which is the electronic. I'm not going to be able to remember what that is now because I just click on ERIS rather than the title. It's a record sharing platform, and that allows us to input like DNA CPRs onto the system, advanced care plans, your community care pathways as well that I spoke about, the yellow sheets for NWAS clinicians. They would have kind of a tick against the DNA CPR or end of life care plan, and it should have the location of where that is. Again, we're having to make very, very quick decisions on scene as ambulance staff. Very, very quick ones indeed. You know, where we're turning up, someone's unconscious, they might potentially be in cardiac arrest. So I think until we've built kind of a good knowledge of what's happening for that patient, again, it is acceptable to perform cardiopulmonary resuscitation, kind of basic life support, if there's nothing telling you not to, because it's much easier to cease basic life support than it is to begin it once you think, oh gosh, I should have done that. But I think the key thing is just trying to gather as much information while you're doing that. Just trying to speak to people that are there on scene, trying to find out, do you have any long-term or palliative conditions? Is there anything that we think we could be kind of going down our diagnosis of death procedure for? Because if you read the revised policy for NWAS, if you're an NWAS staff member, then again, it's all in there for us as ambulance clinicians. And it's, again, that section's for paramedics or above to fill in. So I think it's just all about, again, gathering that information, trying to make the best decision that you can, because no one goes out to these patients wanting to make an incorrect or kind of, well, no one goes out there maliciously to harm someone or make an incorrect decision. So I think the same kind of premises, and I know it sounds a bit similar to my first answer, but sharing that decision and just trying to gain as much information as possible. I just think the more information we can gain, the more we can kind of support a decision to do something with that information. So I hope that answers your question.
Thank you very much, Kieran. So our next question is from Noel Dixon. So with paramedics having to make such big decisions on a person's end of life care, why in the UK is documentation not completely universal in its meaning and definition, instead of having grey areas and different types of forms?
Oh, I honestly, if I could campaign, if I could have a soapbox, I think I'd have a lot of paramedics stood on the soapbox with me. But I'd love to have a unified document. I mean, the DNA CPR is a unified document. Again, these documents in future, there might be something that comes out that's mandatory. I think the only way for us to really safeguard and kind of mitigate against that is to have knowledge of what a form should look like and what properties it should have. So in the show notes that I've got as one of the handouts, there's different properties for what each form should have on it, regardless of what paper it's written on and regardless of like the headed type of document and the NHS logo on it. I think respect was kind of the big opportunity in a way, and I'm not talking down about the process in any way. I mean, these are my personal views as well. I think respect was an opportunity to get that kind of unified documentation out there, because it's a unified advanced statement. I guess there's more to it than a DNA CPR. But yeah, I would happily campaign with you if you wanted to about unified documentation. But I think the take-home message is knowing the properties of what a document should have on it, and then what type of document that then makes it. So the points for an advanced decision to refuse treatment, again, it doesn't have to be on the same paper every time. And I discussed this with the end of life care group recently on a conference call, that it's what's on the paper that matters rather than the paper it's written on. So it's just kind of using the principles of advanced care planning to look and see if that document is legal, if it's informal and not legally binding, and just using those pointers to kind of put it into a category in your mind. That's how I do it in practice anyway. I hope that helps.
That's brilliant. Thank you very much, Kieran. We've got another question from Agnes. Agnes asks, is an ADRT normally on a specific piece of paper, i.e. yellow or red?
Commonly they are, but as mentioned again with the previous question, that they're sometimes on different looking paper. You all have to have the same properties. So the notes that I've put against the show, it has to document and dictate specific treatment. It can be referred to as a living will and be on a piece of paper that says living will or advanced decision. It needs to ensure that a patient or that person is over 18. Otherwise, again, the paediatric side, there's a lot more complexities that need to build anything along those lines. And my understanding of the paediatric documentation is a lot less to the adult side. But as I understand an ADRT, 18 years or over, it could be, as you ask, it could be on different looking paper. I think that's the best way to put it. So it could be on white with red border. It could be on blue with white border. I've seen a variety of kind of advanced decisions on different paper. I think the key point that I mentioned before is it must be signed by a witness and dated. It must state, I refuse X, Y, or Z treatment, and I understand refusing this treatment could result in serious harm or death. If the statement's not got that on there, then it's not a valid statement, and we'd be more thinking that, well, it's not legally binding. It doesn't stop us following it, but it adds a different spin onto how that would possibly guide our treatment. But yeah, I think those that write these documents should, I don't really want to say that it's a clinician that should write it, but I think a clinician definitely needs to be involved. I mean, I could write one of these tomorrow on a piece of A4 paper, and if it was witnessed and signed and it looked official, it had the right information on it, it would technically be valid. So yeah, it's a difficult one, but I guess the reassurance is if the patient's able to make a decision, we don't even need to consider this paperwork. So I hope that does clear it up a little bit. It's just about remembering the points that this document should meet, regardless of the paper it's written on.
Excellent. Thank you, Kieran. That's very well answered. We are absolutely bombarded with questions. In fact, I think we could probably be here till about 1 o'clock in the morning if we carried on. So we have got a few people put their hand up. For those people who have put their hand up, we will be trying to contact you shortly via the chat and to unlock your microphone for a couple of questions. But before we do, we have a question from Dan. Can a respect form be used solely to make a decision regarding resuscitation of a patient in an emergency, or does a unified do not attempt resuscitate CPR need to be seen as well?
So in some areas, there's been a movement of DNA CPR has been removed and it's been transferred onto a respect document. And that's happened because regardless of which trust is doing it, it's generally, I think across the Northwest, it's been adapted and kind of adopted, should I say, by some trusts over in Manchester. So we're talking different kind of CCGs and trusts that are based in the areas rather than kind of like all of Manchester. So the main thing with it is, and to answer the question, no, you don't need a DNA CPR if you've got a respect form. I think it's the clearest way to put it, because that respect form should have documentation, well, something on it that makes it clear what that person's resuscitation wishes are. So really, I mean, I guess it was partially envisaged that these would replace DNA CPRs, and in some instances they have done. So you would see a respect instead of a DNA CPR. And for any further learning around respect, I know I could talk about it for a very, very long time. On the slide where the respect document is on in the handout, I've put a link to a specific respect learning module on. It's an e-learning module. if you go onto that site, there's also the opportunity, you can click on the respect form and look at what needs to be written in different sections, and it will tell you as well exactly what that form should have on it. The slide itself kind of pointed towards, if you remember the slide, it had kind of like arrows with kind of patient details, priorities and preferences for care, and then there's a resuscitation in brackets CPR decision section on there as well, as well as clinical recommendations for care. The key thing to remember is, again, I treat them the same as DNA CPRs. It's a non-legally binding document, so it is there just to help us build the decision. So we don't need to blindly follow it, but we should be following it if it's got the right information on it. So I hope that makes sense, but don't forget you've got the online module if you really want to delve into the respect document to learn more.
That's brilliant. Thank you very much, Kieran. We've actually had, I think some people put their hands back down, so they're a bit shy tonight, I think, in opening up the microphones. So we'll just do 2 more questions. So the second to last question is from Dorothy, and she asks, in your experience, would you say families and the patient are well prepared for end-of-life care? Do the discussions happen early enough?
In my professional experience now, I'm seeing more of it. Before I took on a role working in the community, I didn't see it kind of in practice, because we were generally called out to the instances as ambulance clinicians where either something had happened that people weren't prepared for, something had happened that had worried the family or the patient. So things like breakthrough pain, other conditions like sepsis and kind of other complications of treatment that, again, it's so difficult to explain everything about what might happen to someone. I think we're doing better for it. And I think the teams I know in the community where I work in West Lancs, that they're really on top of it, and the hospices are providing such good education for people. And there's days where families will be invited to the hospice. The person can go and spend a day there, the patient can spend a day there. And I think we're getting better at it. But previously, as a paramedic on a frontline ambulance, I just remember seeing instances where discussions may have been had, but information hadn't been recalled, or that discussion hadn't been had. So I think we're getting better at it as clinicians and professionals. I think as ambulance crews, I mean, it's very difficult to decide like when we'd be speaking out of turn to discuss end-of-life care with a patient, because we don't know what their illness trajectory is. So it's difficult for us to have that chat whilst we're working on an ambulance and seeing a snapshot of them. But in the community, definitely can build a little bit more of a narrative about that person. We can look at more records. In future, we'll be able to see a lot more as well with the technology that's coming to NWAS. So there's loads in the pipeline to help us out on the front line, really. Loads to help in the control rooms as well, in the EOCs. I think in terms of I just think people need to be more comfortable about discussing it. I think we need to have a change of kind of societal belief about it, but that's another discussion. Definitely worth listening to 𝐤𝐤𝐤𝐬's podcasts if you've got another interest in that. But yeah, thank you. Very, very interesting question, though. I could talk forever about that.
Thank you very much, Kieran. We've got somebody who's going to ask a question. So Oliver is willing to open up his microphone and ask a question for you. So just to see, Oliver, are you there?
Good evening. Yes, can you hear me?
Yeah, I can hear you very well, thank you. I'll leave you to ask your question to Kieran.
Brilliant. Hi, Kieran. It's good to hear you again, mate. It's just a quick question just in relation to sort of QI and service improvement surrounding this, because it's been a subject that for a lot of years, as you said, has caused quite a bit of confusion. Do you think an introduction of some sort of electronic paperwork, so to eliminate the confusion over the variants of paperwork and things like that, might be a move to step forward and enhance end-of-life care pathways and things like that?
Definitely. And the thing that's in the pipeline for, I mean, it's been discussed for a number of years in my area in West Lancs, and it's the CCG that are leading on this, talking about what we call an electronic palliative care coordination system, or an EPACS, which you might have heard that said before. It's a lot of CCGs have tried to implement it, and because of systems not talking to one another, it's been very difficult to get that kind of online. But what the 𝐸PACS should show is any DNA CPR or respect form should be on there. Advanced decisions to refuse treatment should be on there. The plan for that patient, the advanced care plan, should all be online. What we're looking at in future as a service is having kind of a tab as part of our electronic records that would show that information. So that's very much, there's a separate wing of the service looking at that. I'm not directly involved, but it hopefully will be available very soon. You know, certainly hope so within the next kind of 6 months or so. And that'll just give us that kind of live information. So yeah, I believe it's been trialled up in kind of South Cumbria. Again, kind of Morecambe Bay-ish area. And it's been very, very useful just to have access to electronic records. Other trusts do have it, I believe, differing platforms. But yeah, certainly the 𝐸PACS. If you've got any interest in 𝐸PACS, there's a good podcast on it from, I think it's the 𝐥𝐤𝐤𝐞 Palliative Care podcasts. So yeah, does that make sense? Does that kind of answer the question?
Yeah, definitely. I mean, over in the northeast, our sort of CCGs use a system called System 1, which allows GP surgeries to link in with each other for out-of-hours services. So I was just wondering if there was already something in place to look at having a similar system for the pre-hospital sector that we can access to sort of validate documents and so on and so forth. But it sounds like that's well underway, so that's brilliant.
Yeah, definitely. Yeah, thanks for the question as well. So hopefully we'll have a bit more news that can be released soon. So keep your eyes peeled for that.
So from me and everybody else here in CPDme, I firstly just like to say thank you very much, Kieran, for an excellent presentation. I hope you found it okay on your side. And thank you again to everyone that's attended, and have a lovely evening. Thank you very much.